big question nowadays is whether and when to start treatment for hepatitis B. We're learning a lot about perhaps why we should start earlier. Excuse me, I'm a little hoarse this morning. World Health Organization is has a very ambitious goal for us in the world to prevent 90% of infants. Prevention targets. So 90% of infants get birth dose vaccination. That's pretty good in the US. 100% of blood donations screened. Still a few slip through in the US if we're not doing universal PCR screening. 90% have access to safe injections, and that's not just injections, drug use, that's the actual antibiotics, vaccines, et cetera, where people are not reusing needles. 90% of people aware of their infection and 80% treated. So to control hepatitis, viral hepatitis by 2030. Actually, by the way, yesterday was World Hepatitis Day. So this is, I think, very appropriate. It was Baruch Blumberg's birthday, the discoverer of hepatitis B. So here are the WHO targets, and it looks like the US is actually right at the bottom of the pack in terms of being able to get hepatitis B eliminated or controlled by 2030. This will take a major effort of awareness, education, government policy, pharmaceutical companies, healthcare providers, and the public. And the public is really ignorant about hepatitis B. They really have no idea what's going on. So we're lucky that the CDC has now recommended universal screening for hepatitis B and universal vaccination for hepatitis B as of this past spring. So test all adults once, test at-risk persons periodically, but frankly, you shouldn't have to if you vaccinate them. Test any person who requests testing, because it means they're at risk. And of course, test all pregnant women. That's been New York state law forever. Remember, to screen for hepatitis B, you have to do all three tests: S antigen, S antibody, and core. And we've arranged this so now there's one click that can do all three. So universal screening would avert 7 cases of compensated cirrhosis, 3 cases of decompensated cirrhosis, 6 cases of HCC, 2 liver transplants, and 10 hepatitis B related deaths per 100 persons screened. So it's really important that we start doing this. So what do we mean by earlier treatment? Well, earlier treatment means basically making decisions based on DNA and not ALT levels. E antigen and E antibody actually don't really mean anything either. So these are the old, very old phases of hepatitis B activity. Antiviral therapy is not recommended when the ALT is normal in the so-called immune tolerant phase or the immune control phase. All that means is ALT is normal. This is ASLD on top. EASL made it a little more clear, and they called this phase chronic infection because the ALT was not elevated, versus hepatitis because the ALT was elevated. So E antigen negative chronic infection, E antigen negative chronic hepatitis. Unfortunately, the virus did not read these guidelines, and the virus is a continuous variable. It's not broken up into boxes like this. And when you try to do that, you fail. So 40% of patients fall in the indeterminate phase. That is, you can't put them into one of these boxes. I think, we should probably have learned this by now from other viruses. I mean, this data has been available since 2006 from Taiwan, and high DNA levels are associated with increased risk of cirrhosis and an increased risk of HCC. It's pretty obvious. So just being S antigen positive reduces your all-cause mortality here. This is 22,000 patients dramatically. This is without even checking viral load. But the Taiwanese were way ahead of their time when they checked this. And this line here represents 2,000 IUs, which is 10,000 copies. And anything below this line or above that in copy number, there's 10,000, is statistically significantly more likely to die from liver-related disease than patients with below 2,000 IUs. So also from the same study, they looked at patients who were, quote, inactive carriers. We don't use that word anymore, versus controls, and look at the cumulative hazard of HCC in the so-called inactive carriers, because they're not getting treated. And here, the cumulative hazard of progression to liver-related death in the same group. And here's the overall indeterminate group that we were talking about, the 40% that were in the indeterminate phase. Here's the HCC cumulative incidence in those patients who were indeterminate. That is, didn't fall neatly into one of those boxes. And they had basically an 18 times higher risk for HCC development. 18 times. And you're still not treating them. So I don't think the guidelines make a lot of sense. These are APOSL. This is the Asian one, ASLD 2018. There's rumors that it's being updated this year, although it's a secret process. EASL 2017, China 2019, although the Chinese just came out with new guidelines basically saying treat anybody with a detectable HBV DNA. East Asia, the US guidelines in 2021, and many of these will have exceptions for significant fibrosis, extrahepatic manifestations like kidney disease, and then a family history of HCC and cirrhosis. Now, the so-called immune tolerant phase is really not immune tolerant to T cells. It's pretty obvious here. This is Patrick Kennedy's study from the Royal Free in London. And he looked at PD-1 positive CD8 T cells here in E antigen positive patients with normal ALT, with abnormal ALT, and in healthy controls. And as you can see, there's no difference between the so-called immune tolerant and immune active. The T cells are activated. And the older you are, the more the T cells are activated, regardless of this, quote, stage of your hepatitis B. And see, it's easier to see this is the same data, those with the Kaplan-Meier curves. Untreated immune tolerant patients have a significant risk for morbidity and mortality. Here, this is 413 patients, no evidence of cirrhosis, normal ALT. Their 10-year risk of liver cancer was 13%. If they were treated, it was less than twice that. It was 6%, less than half of that, sorry. So two and a half times the increased risk treated versus not treated. I think the answer is pretty obvious here: to treat them and prevent those liver cancers. The 10-year risk of death or liver transplantation is even higher. Here, it's 3 times higher, about 10% versus about 3.5%. So 10 times higher risk, 3 times higher risk for death or transplantation. Now, this is a piece of information that makes me really crazy. The proportion of chronic hepatitis B patients that develop liver cancer outside the current international guidelines. So outside the EASL guidelines, 33% developed HCC. That is, they were not being treated. ASLD of 2018, 46%, and APOSL from 2015, 64% were not being treated. So, this is really insanity. You can see these guidelines are just useless. And I think we all know you don't need to have cirrhosis to develop HCC. You can have cirrhosis. It does happen if you let the virus go long enough, but you don't have to have it. And the vast majority of our liver cancers occur in patients who have normal livers. So normal chronic hepatitis B infection works on immune clearance of infected hepatocytes, but it can result in fibrosis from liver cell regeneration, and activation of stellate cells. But here's a scary thing. Here's a direct carcinogenic effect: clonal hepatocyte expansion and chromosomal HBV integration, which leads to HCC. Now, this data, which is also new, is even scarier, because we know that HBV integration begins with the acute infection. So the virus integrates its DNA into hepatocyte DNA. But you could also look at other things it does in the genome, and it actually translocates chromosomal arms from one chromosome to another, usually 17 to 19. And that's really scary. It's messing with the chromosomes here in the adjacent tissue and in the tumor. It's flipping arms of chromosomes from one chromosome to another. It's very scary. Now, when you look at tumors, the 5-year overall survival, according to the number of HBV integrations in those tumor cells, if you had less than 10 integrations, you had about a 75% 5-year survival. If you had more than 10, it was about a 25% 5-year survival. And all these numbers are highly statistically significant. So events associated with hepatocarcinogenesis can be present at any phase. Actually, integration begins with the acute infection. Current international guidelines are complex, and actually they fail patients with liver cancer, because as you can see the numbers, they don't prevent a very large proportion of liver cancer. So DNA integration is an early event, and it's thought to drive carcinogenesis through several mechanisms. So what about early treatment evidence? Evidence for early treatment. This is a combination study of patients from Taiwan in the REVEAL study cohort and US patients. 2,200 of them. So untreated versus treated. And there was a 77% reduction in risk of HCC development. I mean, that's huge. And look at the p-value here. Now, important to note that HCC is not zero in the treated cohort. It still exists. So it's still important to be screening for HCC in these patients that you're treating, twice a year with ultrasound and AFP. Very helpful, actually, to do that, because if we do have an HCC develop, we can pick it up early and we can cure it. Now, what about treatment? So nucleotide analog treatment reduces the number of transcriptionally active viral integrations in chronic hepatitis B patients. This is a nuke versus placebo study. And you can see here HBV DNA integrations correlate with baseline viral markers. But here, this is a log scale, by the way, so it doesn't look like it's that much different, but it is. There's a huge difference in the fold change in integrations by year 3. And these are fold changes in integrations of dysregulated genes. In addition, clonal size, nucleoside or tide treatment significantly reduces the extent of HBV DNA integration and clonal expansion of hepatocytes over time. So from baseline here, median hepatocyte clone size was 2.1. After 1 year, it dropped to less than half of that. And then by 10 years, there was a 91% reduction in clone size with a decreasing frequency of liver cancer correlating with clone size. Now, finally, this seems counterintuitive to a lot of people. Hepatitis B mono-infected patients develop more liver cancer faster than patients who have HIV and hepatitis B. So why would that be? A study from Hong Kong here. The reason is that HIV patients get treated right away and with 2 drugs that are active against hepatitis B, whereas hepatitis B mono-infected patients don't get treated right away. They have people following the guidelines, waiting for their ALT to jump up. The other thing to remember is we're seeing this big trend now in the US of patients going on non-nucleotide regimens. And their providers forget that they have hepatitis B. And we had our first case, our index case of that was a patient who was S antigen positive, and his doctor switched him to a non-nucleoside HIV regimen, and he ended up actually going into liver failure and ending up with a liver transplant. And the doc actually is still looking for a job. So that was a real problem. So we're seeing this more and more now as patients are switching off tenofovir TAF containing regimens, and people are forgetting that. So if you see a consultation with elevated liver enzymes in a patient on a new HIV regimen, check their hepatitis B. And check the DNA, most importantly, because the antibodies antigen and antibody may not be as reliable. So there are immune tolerant variants that we can see, because we can see S antigen and S antibody at the same time. The S antigen probably represents a variant that has doesn't respond to that surface antibody, but it doesn't really matter because there's no reported resistance to tenofovir or TAF. With entecavir, yes. So you should probably not be using entecavir on these patients who have potential for variants. Oh, sorry. Okay, so let's talk about treatment. Treatment lowers DNA levels, lowers the disease progression to cirrhosis and HCC, decreases the transmission rate, and decreases mortality. Hepatitis B is very contagious among households. I have a patient who got it as a baby from his Haitian nanny, and actually as did his entire family. So it's not just sexually transmitted, it's inter-household. So it's in all secretions, all bodily secretions, tears, nasal secretions, saliva, everything. So if you're treating hepatitis B, you're reducing the transmission rate. And of course, vaccination will also reduce it if you vaccinate people. So what about, is it cost effective? Can we do test and treat? This is data from Saudi Arabia. It's actually incredibly impressive data. It becomes cost effective in a matter of about 5 years, and highly cost effective in a little bit longer than that. And you can see annual liver-related deaths drop dramatically by the year 2030. Similar studies were conducted in Brazil, the Philippines, Uganda, and Uzbekistan with the same conclusions, actually, and I think France as well. So treatment becomes more cost effective, basically this is the 1-year HCC risk. So HCC is more expensive than liver transplant, actually, because to treat it becomes increasingly expensive. And of course, the longer they live, the more treatment they require. Unfortunately, our global cascade here is not doing that well. If 32% of the patients in 94 million are eligible, only 29 million are diagnosed and only 5 million are treated. These are 2021 guidelines, but Paul Martin was in charge of this group. We actually didn't agree with the e antigen consider here or fibrosis. So we wrote our own guidelines. And these were published in March in this new journal. Vinod Rusky started a new journal for the AGA called GastroHep Advances. And he helped us get this published. It's a group of us, actually, including primary care doctors, infectious disease doctors, and hepatologists. And basically, the bottom line is, if you're over 30 years old and your DNA is over 2,000, just treat. Forget about ALT, forget about AST, e antigen, e antibody, none of that stuff matters. It's DNA. And we used age 30 because the World Health Organization uses age 30, also because it takes 30 years to develop an HCC. If you're under 30 or less than 2,000, we can defer treatment and watch, unless you've got an obvious reason to be treated, like a first-degree relative with HCC, or some other obvious reason that you might want to be treated. And then everyone needs to have cirrhosis screening, but the easiest way to do it, of course, is just look at the platelet count. Platelets less than 150, it means they have significant liver disease, and platelets over 150, under 100, I'm sorry, it means they have portal hypertension, and you need to do endoscopy and MRIs on those folks to look for varices and to look for HCC. So nucleoside analog treatment has been shown to reduce the extent of DNA integration. If early treatment helps to reduce HCC risk, is it time to change the approach to treatment initiation? So HBV DNA is a continuous variable. Why try to create artificial categories for a continuous variable? DNA over a very small number, 2,000 or 10,000, leads to much worse outcomes. ALT is not a significant indicator of risk. The longer the virus is allowed to replicate, the more integration events take place. It's cost-effective to test and treat. Test everyone for hepatitis B, just as for HIV and Hep C, and treat over 2,000 IUs. And of course, screen for HCC with ultrasound and AFP in every patient every 6 months. And don't forget that your HIV patients have hepatitis B too, and don't stop hepatitis B treatment in them suddenly, lest you get a flare.